Yes, good morning, everybody. Such a pleasure to be here today, and we are having a very interesting session ahead of us now. I will chair this session together with Dr. Shelley Zeroth from Canada, Dr. Mahesh Shah from India, and we have our discussion, Professor Elmir Omerovic from Gothenburg. And our first presenter is Professor Frieder Braunschweig from Karolinska, talking about primary prophylactic ICD in heart failure. Welcome.
Thank you very much, and thank you for the invitation. So I will address the ICD, and as you will see, there are more questions than answers at the moment. Some disclosures. I think the background is well known to you, and there are many current issues with preventive ICD implantation. First of all, we have identified a high-risk group that we implant with preventive ICDs. However, those represent only a very small portion of those who are at risk for sudden death, and the largest part of those at risk are not covered or not protected by an ICD with today's indications. Then we know that the trials our current guidelines are based on are pretty outdated. You see here that the recruitment periods of these trials were like 2 decades ago, and even the Danish trial recruited 1 decade ago. So this data is not representative anymore for today's heart failure or ischemia treatment. And especially we know that GDMT, especially MRI, ARNI, SGLT2 inhibitors, and CRT have important pro-arrhythmic or anti-arrhythmic properties and decrease the risk of sudden death. And we have seen over the years in the middle figure that the risk of sudden death among heart failure patients included in trials has decreased. And accordingly, in ICD registries on the right-hand side, we see that the number of ICD therapies delivered to these patients is very low, even lower in preventive compared with secondary indications. And that means that many patients are exposed to the full complication risk and cost of the treatment without an apparent clinical benefit. And then the Danish study came, including patients with a non-ischemic etiology. And of course, the ICD did its job by reducing sudden cardiac death by 50%. However, that had no impact on the primary endpoint of all-cause mortality, which was not different between groups. Still, there were significant differences in subgroups or significant interactions, most importantly, according to age. And there was still a benefit from the ICD in the younger patients, and in sub-studies they have shown that above the age of 70 there is no significant survival benefit anymore. Then there was a borderline interaction as to NT-proBNP, pointing towards that patients with more advanced heart failure also may derive benefit from implantation. So this study was not powered for non-inferiority. 58% had a CRT device. It was largely a trial of CRT-P versus CRT-D, and I think it's fair to draw the conclusion that for many patients the CRT pacemaker is a valid choice. We also have some non-randomized studies, and one comes from the SWEET-HF registry, a propensity-matched study that Benedikt Schrage presented in Circulation. And in that population, there was an improvement, survival improvement by ICD implantation and a risk reduction of 27% after 1 year that was sustained after 5 years. And very similarly, in the EU third prospective ICD registry, there was a 27% risk reduction by preventive ICD implantation. Both studies, however, were not performed on the background of SGLT2 inhibitors and ARNI as well. Fair to say that also ICD treatment has improved a lot over the years. Today we have very smart devices that are able to discriminate arrhythmias. The number of unnecessary shocks has dramatically decreased. It's a very rare incidence in our practice today. We can add remote monitoring in order to detect device problems or arrhythmias early, and we can offer VT ablation as a bailout for those who receive ICD shocks. And then the costs have been reduced a lot as well, and we can also offer subcutaneous or substernal devices for those with vascular access problems. On the other hand, apart from the heart failure treatment that has improved, I think we have become more aware of complications like system infections, which increase with the number of device replacements and the complexity. So certainly there's a lot to improve on that side. Our guidelines recommend preventive ICD with the 1A recommendation for those with ischemic etiology and the 2A for those with non-ischemic etiology. Importantly, there are some guardrails against overuse, and it is clearly said that patients should have at least 3 months of optimal medical therapy. I think that is not regularly acknowledged in clinical practice, and very important, patients who are implanted should have a prognosis substantially longer than 1 year with good functional status. But however, the question is, are these guidelines still supported by evidence? How can we better identify those who need an ICD or those who do not? And do we have better predictive criteria than ejection fraction? And one candidate is CMR, of course, which is very promising. CMR can characterize the scars, and we know that all patients who present with ventricular arrhythmia have ventricular scars, fibrosis with conducting channels, regardless if they have ischemic or non-ischemic etiology. We see that in the EP lab when we map these ventricles, even if those with non-ischemic background have more epicardial scars or intramural scars. So this is a recent study, a large population with dilated cardiomyopathy, and they could show that LGE distribution and LGE pattern was predictive of the primary endpoint of sudden cardiac death. And they pooled that into a prediction algorithm together with age, family history of sudden death, NT-proBNP, and left ventricular ejection fraction. And this is, of course, promising to characterize the scar burden of patients and the proarrhythmic risk associated with that. Then there are a lot of other markers that have been approached. Many studies, electrophysiological parameters like periodic repolarization dynamics. This is a sub-study from the EUROCERT project published in Lancet showing a high predictive value to identify patients with a high arrhythmia risk. There are biomarker studies. I put some here with circulating microRNA, and they also built a prediction algorithm based on that, showing a subpopulation with a high ventricular arrhythmia risk. And then we have studies incorporating AI to analyze multifactorial risk factor set up from imaging biomarkers, electrophysiological parameters, and patient characteristics. So there are more models to mention, like the Seattle heart failure models, and many studies around. All of them have in common that they're based on retrospective observations and have not been tested in prospective trials. There's one exclusion from that, the REFINE ICD study that was presented by Derek Exner in this year's ESC conference. This was a study in patients with ejection fraction between 35 and 50%, and they evaluated heart rate turbulence and T-wave alternance. So it was difficult to find patients. The inclusion period extended over 10 years. However, finally, they randomized 300 patients to ICD, 300 to controls. What they found is that in those who did not fulfill the inclusion criteria, had no heart rate turbulence or T-wave alternance, the survival was much better. However, between the two randomized groups, there was no significant difference. And that was on all-cause mortality, but also true for other forms of sudden death or other forms of cardiac or non-cardiac death. In terms of prediction models, the PROPHET consortium has presented a large database tooled from 20 data sets, including 140,000 patients. And the initial aim was to find predictors, a sudden cardiac death risk calculator in both patients with low and high ejection fraction, in order to then design prospective randomized trials in these two populations based on that calculator. So several baseline characteristics were analyzed. The study also included 2,000 patients who underwent CMR. AI, deep learning was applied and so forth. However, the result was very disappointing. First of all, the risk of sudden death was very low, especially in those with higher ejection fraction, like 0.4% per year. So impossible to design an ICD trial in that population. And then the predictive value of different statistical models was very poor, regardless if you included CMR or not. And the C statistics was not very much different from flipping a coin. So the conclusion the consortium draw from this is to kind of redo a MEDIT2 study on the background of modern GDMT in heart failure, and that study is ongoing and tries to recruit. So this concerns patients after myocardial infarction with ejection fraction below 35%. Another approach comes from the MEDIT study group, and they constructed a personalized ICD benefit score, showing us those patients who really have a high risk of suffering from ventricular arrhythmia and a low risk of competing mortality risk. So you see in the figures below that this was significantly discriminative in these different patient groups. You can also access a risk calculator on the internet. And the CONTEMP ICD trial will now randomize patients with a low MEDIT ICD benefit score who are randomized to receive an ICD or not. So this study is planned to recruit over 3,000 patients and is powered for a non-inferiority. And lastly, another ongoing study is in the aging population. Of course, the risk of sudden cardiac death is increasing with age. However, the elderly people have a lot of competing mortality risks and die rather of non-cardiovascular disease or non-sudden cardiac death. And so this French multi-center study will randomize patients 70 years old or older to ICD or non-ICD. They plan to recruit 730 patients with 48 months follow-up, and both ischemic and non-ischemic patients are included. So just to say, with regard to personalized medicine, that in our current sudden cardiac death guidelines, we have a lot of specific recommendation, including genetic testing for cardiomyopathies and cardiogenetic disorders, but I will not go into more details. In summary, I think we can agree on that the guidelines or the evidence behind these guidelines is outdated, and we need current evidence in the era of modern heart failure therapy. So a number of comprehensive prediction models are evolving, but they need to be verified in prospective studies, which are very difficult to perform. I think we need to consider, because it's difficult to randomize patients away from the existing guidelines in clinical practice. There are also economic incentives to implant. I think another point that I briefly want to raise, that risk assessment needs to be dynamic over time. The substrate changes and the risk profile of patient changes. And then on the other side, we need to do further work to decrease the ICD complication risks. And it's very important that we work more on enhanced shared decision-making and patient education, as well as psychological support for our ICD carriers. Thank you very much.
So thank you so much for that presentation. We're going to move on to Professor Wilfred Mullens from Belgium, who is online with us today. And he's going to be talking about CRT. When is OMT? When is OMT in time to proceed with implantation?
Hello, everybody. I'm sorry I couldn't be with you. I got this email yesterday evening that my flight has been canceled to Stockholm. So sorry, Gianluigi, that I couldn't be there. I'll try to explain how you can get most out of CRT as well. And let me just present the case. So this is Brenda. She's 64 years old. She has low ejection fraction, dilated ventricle, NT-proBNP of 1300. She's in sinus rhythm on optical medical therapy. And the first question is, what is the likelihood that she would have a wide QRS? Because this is important. So what is the prevalence of wide QRS in this population? Well, it's up to 30%. So that means that 1 out of 3 of the patients you're treating on a daily basis might be amenable for a class 1 recommended therapy, a therapy that saves lives day by day. Now, next question is, what is the number one reason for a non-response? Because we as investigators talk a lot about CRT or about conduction system pacing, and everybody's talking about non-response. But I'll tell you what the number reason for a non-response is. It's not the lack of the synchrony, it's not an inappropriate lead position, but it's a no implant. Why do I say this? Because we know that only 1 out of 3 of the patients who is eligible for the therapy in Europe actually gets the therapy. That means that there are a lot of low-hanging fruit patients with wide QRS who are not even offered resynchronization therapy. This is really a problem, because if you look at the number needed to treat to save 1 life at 3 years, and you compare conventional medical therapy with CRT, you see that for CRT in that era, well, of course, we didn't have SGLT2 at that moment in time, it was only 8. So meaning there is still a lot of benefit from device therapy, especially with synchronization therapy, on your prognosis of your patients. That's why we give it a class 1 recommendation for low ejection fraction patients with a wide QRS who are already on medical therapy. Let me proceed with Brenda. Brenda has a wide QRS of 155 milliseconds. She has a left bundle branch block and she's on optical medical therapy. The next question now is, which of Brenda's would have most benefit? The ones with ischemic or the ones with non-ischemic cardiomyopathy? Most of you might think it's the non-ischemics, but this is again not true. There are a lot of myths. Myths are untrue stories with regards to device therapy. And one of these myths is that the non-ischemics derive more benefit than the ischemics. This is true when you look at ejection fraction improvement, of course, but it is not true if you look at things that really matter. And what does matter for a patient? First, am I still alive? And secondly, am I going to feel better? So less hospitalizations, less mortality is shown for the ischemics and for the non-ischemics. So the things that really matter for patients, living longer, feeling better, are absolutely equal if you compare ischemics with non-ischemics. Next case, she is on a beta blocker, she's on MRA, and she's on an ACE inhibitor, and you see her in clinic. So she's symptomatic, she has an NT-proBNP of 1300. What do? Do you first change her to SGLT2 and ARNI, or do you recommend going with resynchronization therapy first? This is a little bit more in line with what Friedrich was saying previously. What do you do in the new when you have all these therapies available? Well, let me put this in perspective. First of all, only a minority of patients in the CRT trials were on optical medical therapy. This is not only neglect of the physician, but it also has to do with bradycardia problems and with hypotension. Most patients with a wide QRS do not tolerate the same doses of GDMT because of hypotension or because of arrhythmia-related problems. What's even more concerning is that if you put them on medical therapy, the wide QRS patients, they don't have the same remodeling response. These are observational data on the left, where you see that ejection fraction improvement in the wide QRS population is significantly less than with the narrow QRS population. On the right, you see a prospective randomized trial done in Korea in patients with wide versus narrow QRS. And you see the ones with the wide QRS almost did have significantly less ejection fraction improvements with the wide after starting ARNI therapy. That is the reason why within ESC, we have adopted a different model when we look at resynchronization therapy candidates. So historically, you were diagnosed with heart failure, we were emphasizing medical therapy, and then we said, just wait. Wait, and most of the times nothing will happen if you have a wide QRS. So we moved away from the sequential model to a more integration of device therapy based on phenotyping of your patient. This means that if you have a wide QRS, low ejection fraction, you should think about resynchronization therapy early on. The way we advocate doing this is if you're faced with such a patient, the first time you already talk about device therapy, and when you see the patient back after a couple of weeks, that is the moment where you start discussing the implantation date already, because we know that medical therapy will not kick in the wide QRS population. Let me continue. She is on optical medical therapy, and then the discussion is, are we going to go for a pacemaker or are we going to go for a defibrillator? Now, we know that if we put in the resynchronization therapy, that there will be an improvement in ejection fraction, and this clearly will lead to a reduction in sudden cardiac death rate. But patients will also live longer. So they will live longer with still some depressed ejection fraction. And in that time period, there is still a chance of sudden cardiac death. So you have to individualize. Secondary prevention favors a decision for a defibrillator. Left bundle bench block favors a decision for a pacemaker. Comorbidities, pacemaker. Genes, defibrillator. And SCAR also favors my decision for a defibrillator. So in my clinical practice, 50% of my CRT population receives a pacemaker, and the other 50% receives a defibrillator. Let me continue with Brenda. Are you going to go for classical resynchronization therapy with an endovascular lead in the coronary sinus, or are we going to go for conduction system pacing? I'm not going to go in detail, but I think there is major criticism to routinely replace CRT by LBB area pacing. Why? First of all, there is absolutely no randomized controlled trial looking at endpoints of mortality and heart failure hospitalization. So everything we think is true might not be true in a real trial setting. There is also a huge bias currently in the literature towards conduction system pacing. The safety of the technology has not been proven. There has been reports now of a failure rate of the LBB lead of 0.5% at 2 years, which is considerably higher than with the classical endovascular lead in the coronary sinus. We don't really know where the lead ends up. We know that if you do LV septum pacing, that's probably worse than LBB pacing. The durability of the leads is unsure, and there's definitely more TR, and we don't really know what that will cause on the long term if you're going to do this in heart failure patients. That is why the current guidelines, the society expert documents, still recommend to go for classical CRT over conduction system pacing while we are awaiting more trial data. Last problem now, we're faced with her. She ends up in the ICU with a very high right atrial pressure, high PA pressures, high wedge pressure, and low cardiac output. So you might think she is a non-responder to the technology. But this again is not true, because if you turn off the device, and what you see here are just 4 loops, 2 with the pacemaker on, 2 with the pacemaker off, you see immediate reappearance of the septal flash when you turn the device off. And when you do this in patients in the ICU with a pulmonary artery catheter in place, you see a drop in blood pressure, an increase in wedge pressure, and a drop in cardiac output as soon as you turn off the device. This means that the therapy is still working. This means that the therapy is still providing hemodynamic benefit, but the disease is just progressing. So we should stop talking about response, but changing this by disease modification. And every patient with a wide QRS who has been implanted with resynchronization therapy has a favorable disease modification after their implant. This is really important. When we talk about medical therapy, we will never talk about non-responders. Nobody will take away the ARNI or the beta blocker in HFrEF patients if they end up in the hospital. Yet we talk about response in a device technology for not with medical therapy. It's the same phenomenon. You have disease modification with the therapy, which is something very favorable for the resynchronization therapy. But of course, there are a lot of things you have to do to improve the outcome of your patient. It should not be drugs, device, and then wait, but it should be optimization of GDMT after the CRT implantation, because then there is more room to do that. Optimization of the device settings, optimization of the comorbidities, and putting all patients in remote monitoring programs. If you do that, so optimization of the device, of the patient, and remote follow-up, you see you can really improve the prognosis of such CRT candidates. So I'm going to stop here. There is room for improvement. First of all, overcome the underutilization. Secondly, stop talking about response, but change it to disease modification. Try to understand a little bit better what resynchronization therapy actually does, and offer a guide for a structured post-implant care that will improve outcomes in your patients. I thank you for your attention.
Thank you so much. Our next speaker is Dr. Mariana Adamo from Italy on TR, a treatment target, and heart failure.
Good morning, everybody, and thanks to Gianluigi for the invitation. Sorry for not being there, but I am sick. So I'm supposed to talk about tricuspid regurgitation and to try to argument on whether this can be a target treatment in a heart failure. Let me start with some epidemiological data, just to remind you that TR is a really common condition in patients undergoing echocardiography in an ambulatory setting or in the hospital. And the prevalence of TR is high, as you can see, about 30%, and the moderate or severe TR is observed in 9% of patients. And the prognostic impact is strictly related with the TR severity. Now, this is a meta-analysis of observational studies showing that this association between TR and mortality is independent on different parameters that can be confounding factors like right ventricular function, pulmonary hypertension, atrial fibrillation, left ventricular dysfunction, and concomitant mitral regurgitation. This is the largest cohort of patients with chronic heart failure where patients were stratified according to the heart failure phenotype and according to the TR severity. And as you can see on the left, there is an increase in TR prevalence according to the patient age, as expected, but also more interestingly, as you can see, the prevalence of TR is higher, in particular severe TR in red is higher in patients with FREF as compared to patients with FF, where the prevalence is about 9–10%. But if we look at the absolute number, the amount of patients with severe TR is higher in patients with FPF, since FPF is the largest population, of course. And if we look at the Kaplan-Meier curves, again, regardless of a heart failure phenotype, a severe TR is associated with a poorest outcome as compared to the other TR grades. Now, this is an association, it's not a cause-effect relationship, so we should try to understand whether a treatment of TR is related to an improvement in outcome. And we have registries, including patients undergoing transcatheter treatment of the tricuspid valve, where a procedural success is associated with a better survival as compared to a procedural failure. This can be, of course, influenced by many factors like the stage of disease, the complexity in the anatomy, and so on. we have this more recent data showing again that a residual TR 2+ or less is associated with a better survival as compared to a residual TR severe or more than severe, independently on possible confounders like right ventricular dimension and function, symptoms, and so on. But again, these are observational studies, single arm studies. Let's look at randomized control trial. We have 3 randomized control trials comparing transcatheter therapies versus medical therapy in patients with severe symptomatic TR. The TriILLUMINATE comparing TriClip versus medical therapy, the TriFAR with a similar design, and the TriSYND comparing the EVOQUE valve versus medical therapy with a randomization 2-to-1. The TriILLUMINATE was the first published randomized control trial. This was the primary endpoint, a hierarchical endpoint including mortality, heart failure hospitalization, tricuspid valve surgery, and the improvement in quality of life. The primary endpoint was met, totally driven by an improvement in KCCQ, which was huge, which was related to the amount of TR reduction, but in an unblinded randomized control trial. And these are the results at 2-year follow-up. After 1 year, there is a separation of the Kaplan-Meier curves with an advantage for the device arm in terms of cumulative heart failure hospitalization. But this is a bit difficult to interpret because a high proportion of patients underwent a crossover from the medical therapy arm to the device arm after 1 year. This is the second trial, the TriFAR, showing again an advantage for the device group, but only in terms of patient-reported outcome, patient global assessment, and NIA class, whereas for the other endpoints, there is no significant difference. There is a trend for heart failure hospitalization, but as you can see, numbers are really, really low. This is the TriSYND-2 trial comparing EVOQUE versus medical therapy. Again, a hierarchical endpoint met as a primary endpoint, but totally driven by KCCQ improvement and the NIA class improvement. No difference in terms of mortality and heart failure hospitalization. What is the problem here? The problem is that the TR population is a really heterogeneous population, like in mitral, but even worse probably. We have many phenotypes, many possible mechanisms behind this TR that can be the final step of a disease or can be a contributor. It depends on the phenotype. So if we look at the baseline characteristics of the TriILLUMINATE trial, which is the only one that I would consider strong because there is this signal towards a trend for heart failure hospitalization improvement, even if with all the limitations related to the crossover and the design of the trial. But if we look at these characteristics, these patients are old females, hypertensive, with atrial fibrillation, with dilated tricuspid valve annulus, with preserved ejection fraction. These patients seems to have a benefit in terms of quality of life and maybe a benefit in terms of reduction in heart failure hospitalization. And if we look at this registry, the TRIGISTRY, including patients undergoing transcatheter treatment or conservative care. This is only an observational study, it's not a randomized trial. There is a comparison made by a propensity matched analysis. As you can see, if we stratify patients according to the left ventricular ejection fraction, it's interesting to observe that in patients with a preserved ejection fraction, there is an advantage for the device, whereas in patients with the reduced ejection fraction, there is no difference. So this means that different phenotype could respond differently to the treatment. Also, in addition to the phenotype, it's really important to consider the stage of disease, because probably we should avoid to treat advanced stages, as we have learned by surgical studies. So if we treat at a too advanced stage of disease, the intervention is futile. This is another registry showing again comparing the device versus medical therapy and stratifying patients according to the stage of disease defined according to the left ventricular function, right ventricular function, and biomarkers and renal function, that patients at an intermediate stage of disease have an advantage with the devices compared to medical therapy. Whereas in the early stage and in the advanced stage, there is no difference. So to conclude, TR is associated with a poor prognosis in patients with or without heart failure. Observational studies show the possible association between successful transcatheter treatment and survival. Randomized controlled trials showed an advantage for transcatheter treatment all in terms of quality of life and an initial signal in terms of heart failure hospitalization after 1 year. Other studies are surely needed and urgently needed to better understand the role of these therapies and to try to understand what are the best patients to treat with invasive therapies. But we need studies better designed, and this is a suggestion. I advise you to read this reading paper where we tried to summarize the analysis on future studies for atrial valvular intervention. So trying to optimize patient selection, the choice of the endpoints, and the consideration of guideline-directed medical therapy in addition to devices. Thanks for your attention.
Thank you so much, Mariana. We're going to move on to Dr. Andreas Ruck from Sweden, talking about treating aortic stenosis in HFrEF. When is it too late or too early?
Thank you for the invitation. So I'll talk about TAVI in severe heart failure, too late, or I put the title life-saving. So I'd like to start with a case, 84-year-old male, prior history of CABG. He has now shown up at the hospital. He's an inpatient with heart failure. Ejection fraction is low, only 20%. And the measurements across the aortic valve on the Doppler are Vmax 3.5 meters per second, mean pressure gradient 35, and a velocity index of only 0.16, thus a low flow, low gradient aortic stenosis. So I'd just like to put a vote out here. Here are the 4 options. I decided already there might be more than 4 possible options. One is to say it's futile, his ventricle is burnt out. No TAVI, that's number 1. Number 2, we need to stratify somehow, maybe stress echo to assess the contractile reserve. If that one is positive, then maybe do a TAVI. Or number 3, maybe medical optimization first, then go home, come back for a TAVI a bit later, or just go for the TAVI tomorrow and do the rest later. So who is in favor of option number 1? Raise of hands. Nobody. Okay. Strong interventional bias in the room. That makes me happy. Good. Number 2, stress echo first.
Here's one.
Nobody for stress echo? A couple. Yeah. Okay. Number 3, medical optimization. Go home, come back for TAVI later. A few. Number 4, TAVI tomorrow. 2. Seems to be a quite split vote. I didn't really see the majority. Bahira, what was the most popular option?
I think I chose 4 because I think that's what we did at our center.
Yeah, okay. Yes, exactly. Karolinska should be the rule. That's the way. Yeah. So just since you're a heart failure specialist, I'm just reiterating some of the evidence for TAVI. This is really old evidence. In the beginning, the PARTNER 1 study randomizing medical treatment or TAVI, that's the only study, since the absolute difference in total mortality was 20%, and that mortality difference was actually maintained over 5 years, meaning an NNT of 5. Then moving on to the operable patients, comparing with surgery, maybe not the topic for this talk, but still in some studies we have shown that on MACE endpoints, the TAVI group was faring better, and in some other trials at least the same as for surgical replacement. Then moving on to patients similar to the one I presented, low flow, low gradient aortic stenosis patients, Is there a benefit there? In the same study, that means randomized between TAVI and medical management, there is a similar mortality benefit also in these patients in the quite old nowadays Partner 1 study. Then there are a couple of registries specifically for low-flow, low-gradient aortic stenosis, and the concept of the dobutamine stress echo and contractility reserve was or has been quite popular to stratify the patients into the ones, presumably then, if you have a contractile reserve, you deserve to be treated and your ventricle will improve more, versus if you don't have it. Actually, it shows in this study that there is no difference. So the red curves here are without contractile reserve, and you see in the top ones that there is no difference in the mortality after the TAVI procedure. And in the lower part, you see that the improvement of ejection fraction is also not dependent on the contractile reserve, which also means that in the latest guidelines for valvular disease, this contractility assessment has been downgraded. Looking then specifically into really low ejection fraction versus 30 to 40% EF, and just the improvement in EF first before and then discharge, and then the third data point is here 1 year. You see that the ones who start out with a really low ejection fraction, they improve the most in ejection fraction, maybe not a surprise. Digging more into this really low ejection fraction group, this is now a registry. Again, of course, there are patients which are not treated at all. They're not in these registries, but these are patients that are treated with TAVI. And you see here that in the very low ejection fraction group, the mortality in hospital was still low, only 2%, 30-day mortality also quite low, 9%, and at 1 year, only 13%. So it seems like these patients, at least in this registry, were quite well selected, and in selected patients, we have outcomes which are quite similar to other patients with less depressed LV function. Notably, in this registry, exactly one patient used an ECMO during the procedure for support. Digging into our own databases at Karolinska a couple of years back, I found these numbers. So ejection fraction less than 30%, only 7% of the total TAVI population in our center, but still 61 patients found. 30-day mortality is still low. You see in the other patients virtually no mortality, but still only 3%, which I think is very acceptable. It seems we treated maybe a little bit sicker patients than in the other registries I showed, but still I think a 29% 1-year mortality is probably still acceptable in these patients. Of course, we would like to select the best responders too, like in other therapies we have discussed already, but I think this is probably quite okay. Coming back to the guidelines, just mentioning that asymptomatic patients nowadays are also accepted or could be accepted for aortic valve replacement across the board with a 2A indication, and specifically for patients with an ejection fraction less than 50%, it's a class 1 indication, even if they are asymptomatic on medical treatment. So then lots of therapists try to expand into broader areas. So of course there could be the concept that if you have a failing left ventricle, maybe it's not so good to have even a moderate aortic stenosis. Maybe that should be taken away and unloading the ventricle. There is one such trial presented this year, the TAVR Unload trial, rather small but randomized. It's ejection fraction 20 to 50% and an aortic valve area of 1.0 to 1.5, meaning a moderate aortic stenosis. Patients received GDMT or GDMT plus TAVI. And as you see, the composite endpoint here and in this curve, no difference between the groups. So we don't need to unload moderate aortic stenosis. Still, we're treating only severe as of now. So these patients come to us in a couple of different scenarios, and they are also not only different with the ventricle and the aortic stenosis, but especially also with the comorbidities noted in the bottom here. They might come to us as outpatients, maybe patients with known heart failure, and then we discover that they have severe aortic stenosis. They might be inpatients, like the one patient I showed in the beginning, or in the worst case, they might be inpatients even with cardiac shock And I think if we decide to replace the aortic valve, it's really dependent on the comorbidities in these patients. If they have severe coronary disease, severe alveolar disease, high PA pressure, severe kidney dysfunction, or are very old, that of course makes a big difference on this discussion, which needs to be taken with the patient and the relatives. This one is unanswered. Should we go strict in outpatients for the 4 pillars, let them work for a little while and then replace the valve? Or should we just call one of these 3 happy guys here and have them implant the valve right away and then send the patient on to the heart failure clinic? We're not completely sure about that yet, but I think most patients go for the TAVI first, pills later approach in outpatients. And if you do the TAVI in severe heart failure patients, there are a couple of considerations. One is that in a few patients, we need ECMO support, and then we need an ECMO on standby in the room. We don't have it as routine in other patients. Some patients might need ICU for fluid and blood pressure management before and after, and then the procedure itself should be short and swift with transfemoral approach and without general anesthesia. So, how did it go? Seems like we went for option number 4. TAVI was done the next day. No ECMO we decided not to have an ECMO in the room. He needed a bit of noradrenaline during the procedure and could be discharged 3 days later on medical management, of course. So to sum it up, TAVI in heart failure with reduced ejection fraction. It's a low-risk procedure, high benefit in most patients except severe comorbidity. The indication should be made quite early. Medical treatment is important. For outpatients, I think it should be done without too much waiting time, put here 2 weeks, and for inpatients should be done as soon as possible. Thank you.
Andreas, you forgot to tell us, is the patient still alive?
I haven't checked. I made the case like a year ago. I hope so.
Thank you very much. We will take the questions in the end of the session. So now it's a pleasure to welcome Professor Marco Metra from Italy to give us a talk on treatment of FMR.
Thank you, Bahira. Thank you, Gianluigi, for your kind invitation and the topic. So I will just talk about mitral regurgitation, how to treat it, and then you will see the indications from the guidelines by, I guess, Mariana Damu. These were the guidelines that I co-chaired in 2021, and it was the first. You see that I had many friends on board, and this was the first time where we included the treatment of mitral regurgitation as a component of the treatment of heart failure. And there were 2 things to be done before considering the intervention. One, if the patient had an indication to coronary artery disease surgery, and with secondary mitral regurgitation, he has an indication to surgical treatment. And the other thing was optimization of medical treatment. This because we have data that show very consistently that mitral regurgitation is dynamic and can be favorably affected by medical treatment. This is an analysis of Biostat, a registry that I had the pleasure to work on with the group in Groningen. And you see that ACE inhibitor treatment was an independent predictor of regression of mitral regurgitation. These are data from a series in Vienna, and you see that guidelines-directed medical treatment for heart failure is associated with an improvement in mitral regurgitation. Then what about the indication to transcatheter treatment or surgery? Surgery is class 2B, lower priority, and percutaneous treatment at the class 2A indication, so should be considered in patients who fulfill the criteria. Which are the criteria? the criteria were based on the COAPT trial, because this was the only trial showing a favorable result of transcatheter treatment, whereas MITRA-FR did not show any difference between transcatheter treatment and control group. Of course, there has been a long discussion regarding these data, but on the other hand, I wanted to emphasize that the results in COAPT were significant, both with regards of hospitalizations for heart failure alone, but also with regards of all-cause mortality, which is, of course, a very strong endpoint. So where we came with the 2021 guidelines 5 years ago is with an indication to treatment, transcatheter treatment, when the patients fulfilled the criteria of COAPT. Absence of severe right ventricular dysfunction or severe tricuspid regurgitation and hemodynamic stability. Are these criteria still valid? Yes. This is an analysis we did from a 3 centers study group, and you see that the patients with the exclusion criteria from COAPT had a poorer outcome after transcatheter treatment. On the other hand, in the real world, already years ago, most of the patients who underwent transcatheter treatment, at least 55%, did not fulfill the COAPT-like criteria. And so it came ReShape-HF2 by Stefan Anker and co-workers, where we had a broader, slightly broader inclusion criteria, symptomatic heart failure, hospitalizations, and IG or IG NT-proBNP plasma concentrations. However, the exclusion criteria, some exclusion criteria remained, including hemodynamic instability and severe right ventricular failure or severe tricuspid regurgitation. The patients were randomized to control or device, and they had some other differences compared to the previous trials. ReShape-HF2 included patients also with moderate to severe mitral regurgitation, and therefore, if we look here, the EROA was 0.25 in ReShape-2 compared to 0.4 in COAPT and 0.30 in MITRA-FR. And the patients also had, however, a relatively small left ventricular end diastolic volume, so that they are located at this intersection compared with MITRA-FR, major left ventricular dysfunction, and compared with COAPT, where the severity of mitral regurgitation was greater. The results were a highly significant reduction in heart failure hospitalizations and the primary outcome with transcatheter treatment of mitral regurgitation compared to usual therapy, and also an improvement in quality of life. All-cause mortality alone was not affected, but the patients were less severe compared with COAPT. And you see this further analysis with a reduction in heart failure hospitalization and cardiovascular hospitalizations. Markus Anker also did a meta-analysis of the 3 trials in secondary mitral regurgitation, confirming the reduction in heart failure hospitalizations and also a borderline numerical reduction in cardiovascular death. And so we come to the 2025 guidelines with a class 1 recommendation, but I don't want to spend time on this. But I wish to point out some other knowledge gaps that we are still having. If you look at the guidelines, this is the algorithm for ventricular mitral regurgitation, but still there is the issue of atrial secondary mitral regurgitation. In this case, is this a minority of the patients with a secondary mitral regurgitation? According to some early analysis, yes. In this analysis we did from the EuroSMR registry, only 8% of the patients had atrial mitral regurgitation. Nevertheless, they improved after transcatheter treatment, and nevertheless, they had an outcome similar to the patient with ventricular secondary mitral regurgitation with right ventricular dysfunction, which was an independent determinant of outcome. In this more recent review published in ESCR Failure, we found that the prevalence of atrial mitral regurgitation is roughly 40 to 65% of all the patients with functional mitral regurgitation. These patients have a preserved left ventricular ejection fraction most of the times. They have left atrial cardiomyopathy, and they have a left atrial dilatation and annular dilatation. In these patients, there is, still medical treatment, mostly for FPEF, but there is also the issue of rhythm control, which may have a major role. We still cannot say whether it has to be done before or after transcatheter treatment. We will see the guidelines later, but pulmonary vein isolation is surely an option in these patients. And then we have that the guidelines privilege surgery versus transcatheter treatment when feasible. We will see more later. Another knowledge gap, I think, regards the severity of mitral regurgitation. You see that the guidelines are focused on severe mitral regurgitation, but nevertheless, we have also the patients with moderate mitral regurgitation. And we have no data except this interesting analysis from a registry which was done for patients with severe mitral regurgitation, but with a significant proportion of patients who had a mitral regurgitation measured as moderate at the central core lab. And the results are that the efficacy of transcatheter treatment of FMR was similar both with respect to left ventricular remodeling and with respect on quality of life compared to the treatment of severe mitral regurgitation. And the outcome was also similar in these two study groups. In any case, we have moderate mitral regurgitation, which is present, found in a significant proportion of patients, and we still don't know the role of transcatheter treatment. Last slides, 1 minute, the outcome of the patients. This is an analysis of all the registries done by Christian Basile and Gianluigi Savarese, and you see that we have a mortality which at 30 days is roughly 3%, at 1 year is 17%, but what is dramatic is the long-term follow-up of these patients. In COAPT, even the patients who underwent the device therapy had a 57% 5 years mortality from any cause. This is another registry, 35% survival at 5 years, and again, a poorer survival in the patients who have, of course, advanced New York Heart Functional Class, reduced kidney function, who are ineligible for COAPT again, And last but not least, the patients who are not on guidelines-directed medical treatment. So my last slide is to recall that medical treatment can be optimized also after transcatheter treatment, and actually some major limitations such as hypotension may be overcome by transcatheter treatment. And in this analysis, mitral regurgitation reduction was an independent predictor of the likelihood of optimization of guidelines-directed medical treatment, and this was associated with a better outcome. Thank you for your attention.
Thank you so much, Marco. We have one final talk here with Mariana is coming back online to tell us about the new ESC guidelines.
Thank you again. So some concepts have been anticipated in the previous presentations, so easiest to work for me. This is one of the main illustration of the new valvular heart disease guidelines, where, as you can see, the heart failure cardiologist is included in the heart team members for the discussion and decision in patients with valvular heart disease candidates for possible intervention. So let's start with the aortic stenosis. We have already seen that the butamine echocardiography is not mandatory in these new guidelines for the diagnosis of low flow, low gradient aortic stenosis with reduced ejection fraction, but a calcium score evaluation is enough. And also the recommendation for intervention in these patients is irrespective of evidence of flow contractile reserve with a class 1 indication, so for both patients with high gradient aortic stenosis and patients with low flow, low gradient aortic stenosis and reduced ejection fraction. We have already seen also that there is an expansion of indications for TAVI or for intervention in general, also to patients asymptomatic with a preserved ejection fraction and high gradient based on randomized control trials with some limitations. And this is the reason why we have a class 2A rather than 1, even if the level of evidence is A, because we have 4 randomized control trials comparing early surgery or early TAVR versus clinical surveillance. Then regarding TAVI, expansion of the indication also to younger patients. So the cutoff age is now 70. And so patients with more or equal to 7 years with a tricuspid valve and anatomy suitable for TAVI have an indication class 1 for TAVI. On the other hand, patients with less than 70 years, if the surgical risk is low, must undergo surgery. All the other patients have to be discussed. But let's say that it's really important, regardless of age, to consider and regardless of the surgical risk, to consider the lifetime management in these patients and the life expectancy, because we know from recent long-term data comparing TAVI versus surgery that the outcome of these patients undergoing TAVI is really good, with non-inferiority or superiority of TAVI as compared to surgery and the good durability of these TAVI valves. But we have to consider, we have to try to have an holistic approach considering anatomical, clinical aspects in order to personalize treatment, the kind of prosthesis, the kind of intervention according to the patient characteristics. Regarding mitral regurgitation, I would focus on secondary MR because this is more related to heart failure. And in the new guidelines, we have these new definitions and the distinction between atrial and ventricular MR. So ventricular MR is the classical, let's say, form of secondary MR and is always reported also in previous guidelines. In previous guidelines, when we talk about secondary MR, we refer to ventricular MR. So with the reduced ejection fraction, with the normal leaflet morphology, dilated or dysfunction of the left ventricle, and so on. But we have this other phenotype already mentioned, the atrial SMR with the preserved ejection fraction, often associated with the atrial fibrillation, atriomyopathy, and HFpEF. And we have an upgrade for ventricular secondary MR in absence of coronary artery disease, an upgrade of the indication for TEER, for transcatheter edge-to-edge repair, which is now recommended to reduce heart failure hospitalization and improve quality of life in hemodynamically stable patients symptomatic with reduced ejection fraction and persistent significant mitral regurgitation despite medical therapy fulfilling specific clinical and echocardiographic criteria. Class 1 level of evidence A is a complex wording, but this is to say that patients have to be really well selected based on these criteria. In particular, I would like to remind you the absence of advanced heart failure, the absence of severe pulmonary hypertension, and the absence of severe right ventricular dysfunction or other valvulopathies or coronary artery disease. And this class 1 indication is based on the 3 randomized controlled trials Mark already showed, summarized in this meta-analysis, showing a clear advantage despite a neutral trial included, a clear advantage in terms of heart failure hospitalization at 2 years, with a trend towards an advantage also in terms of mortality. Regarding atrial SMR, as already mentioned, we have new indications in these guidelines, both based on registries, because we don't have randomized controlled trial in this field. We have one indication, class 2A for surgery, in association with AFib ablation and LAA occlusion, and an indication 2B for transcatheter after optimization of medical therapy. And this is the algorithm, the current algorithm distinguishing between the ventricular and atrial. I would just, with all the recommendations that we have seen, more or less, I would like just to pointing out again that the optimization of medications before the intervention is crucial for both ventricular and atrial. For ventricular with GDMT, for FREF, for atrial with optimization of treatment for FREF and rhythm or rate control. Regarding tricuspid, we have this new recommendation, which is quite generic, but it's really important because it says that we have to look at TR and try to understand the stage of disease, the etiology, and the specific characteristics of that patient before considering any kind of intervention. And a step-by-step approach is proposed, including the evaluation of the clinical history, echocardiography, right heart cath, advanced images like CT or transesophageal echo, the evaluation of the risk, surgical risk according to new scores like the TRI-score. And the heart team then has to discuss the single patient to try to find a tailored solution for each patient. So this is the algorithm, similar to 21, to be honest. So there is the differentiation between TR with need for left side valve surgery or without need for left side valve surgery. On the right, the indication is basically a surgical indication if there is a concomitant left side valve disease to treat. With these recommendations, with a different class according to the grade of associated TR. If the TR is isolated, we have to exclude severe right ventricular or left ventricular dysfunction, severe precapillary pulmonary hypertension, and we have then to choose between surgery or transcatheter according to the heart team discussion. And we have an upgrade here for transcatheter therapies from 2B to 2A based on the 3 randomized control trials I showed in the previous presentation. So 2A, level of evidence A. So to conclude, the new messages from guidelines are that heart failure specialist is included in the heart team. There is, has to be included in the heart team. The dobutamine stress echo is not mandatory for the diagnosis of low flow, low-gradient aortic stenosis with reduced ejection fraction. TAVI indications are expanded to asymptomatic patients and younger patients. For secondary MR, we have a new classification in distinction in atrial versus ventricular with an upgrade of tier indication for ventricular SMR class 1 and new indications class 2A and 2B for atrial SMR respectively for surgery and TEER. And also for TR, we have some step forward because we have an upgrade for transcatheter therapies in patients symptomatic with severe regurgitation. Thank you for your attention.
Thank you so much, Mariana, for that precisely 10-minute talk. We love it. We're a little over time. We're going to abbreviate our discussion because we do have lecture 2 coming up. I just wanted to know if our chairperson from India, Dr. Shah, may want to have some comments or perhaps a question for our distinguished speakers.
Yes, I think all the speakers did a fantastic job of a very difficult subject. Till ESC 2025 guidelines, a lot of things were kind of expert opinion based. It was more of an art. Now my question to Dr. Frieda Braunschweig is how frequently, because we know that DAPA-HF trial, every 5% increase in ejection fraction was associated with reverse remodeling, which reverse remodeling with foundational 4 therapy continues up to 6 months or 1 year from the start of therapy, and the indications for ICD might change over time. So how frequently do you evaluate and do you reclassify the patients? And have you seen some reduction in need for ICD ever since this foundational 4 therapy has been prevalent?
Okay, thank you very much. If I understand your question correctly, it regards to the antiarrhythmic properties of SGLT2 inhibition, and that has been shown in sub-studies of the different trials that you have effects on both the incidence of atrial fibrillation and ventricular tachycardia and the risk of sudden death. So the same has been shown for ARNIs, and we know the same properties are present in MRI. And of course, if you add CRT to GDMT, we have a number of potent therapies that not only improve heart failure, but specifically reduce sudden cardiac death risk. So therefore, I think the guideline, what the guidelines say that we should have at least 3 months of optimal medical therapy is very important. And that is something we not consequently follow in clinical practice, but we should do. Then your question as to the longitudinal re-evaluation of arrhythmia risk, that is, of course, very important as well. Patients can deteriorate in their ejection fraction and other risk markers. And even re-evaluation in those who have been implanted with an ICD is important. Many patients improve in their ejection fraction. And if there's a lack of myocardial substrate, if they have no scar on the CMR, if upon the first device exchange there is no documentation of arrhythmia in the device memory, then a downgrading or explantation of the device should be discussed. On the other hand, we know that these substrates develop over time, and arrhythmia risk actually can increase over time as well by fatty infiltration of these arrhythmia substrates. And we know from the MUDDI trial that many of the ventricular arrhythmias occurred late during follow-up, and that what we are seeing in the VT ablation lab as well, many patients who present with ICD shocks and come for VD ablation have a remote myocardial infarction that is sometimes 10 or 15 years old.
Yes, thank you so much. We will lead in Professor Elmir Umerovic as a discussant.
Can I ask a question myself?
Yes, absolutely.
I would like to ask my colleague, Andreas. I think you did a very good job to convince us that TAVI are needed and we should use it more. But because I know that you are very good at implanting TAVIs, and I know that you are very active in our national registries, I would like to put on your spot and ask you which of the valves that we have is the best one, or why don't we have head-to-head comparison when it comes to the TAVI, given their price, their characteristic, and so on? So what's your opinion?
That's a good question. We have recently been in talks over the last year with more than one company on designing such a trial. There are some coming out of Denmark. They compare series of studies, same study group that also compared coronary stents. Usually you find there's no difference. We don't know for sure in TAVI. So the major two vendors, that's Edwards and Medtronic, are not interested in a dogfight between these big two companies. They probably cannot win anything on the market from it. But if you're a smaller company and you want to have your valve approved in the US, then you need to establish that you are as good as one other valve on the market. So that means there is a lack of such studies, but there are a few studies comparing valves. In general, you will find that they are maybe one valve gives a bit more pacemakers, but might have a little less power valve leak or some other details. But on the grand total in the scheme, so far we don't see any big differences between the valves. Both the balloon expandable now has shown quite favorable 7 years data. We have 10 years data with self-expanding valve, etc. So it seems we probably the products are rather similar, but we don't know the details yet.
Thank you. So I have a question for Dr. Mariano. The ESC, the new ESC valve guidelines are, as we heard, mainly based on consensus in many cases, such as the recommendation for surgical ablation in atrial SMR. But the thing is that it's difficult because at the same time the ESC guidelines now recommend minimal invasive surgery. So what are your thoughts on that?
That's a good question. As mentioned by Marco, this is a huge evidence gap because in the context of atrial MR, we don't have a randomized control trial. And indeed, probably in the past, this phenotype was misclassified as a primary because these patients have a preserved ejection fraction. FPEF was not a recognized entity in the surgical studies in the past. So, I mean, we are now studying this setting of patients. And so the two recommendations are based on registries. The recommendation 2A-B for surgery and AFib ablation is based on a large registry, including patients undergoing conservative management or AFib ablation plus mitral valve annuloplasty with a comparison made by a propensity matched analysis, showing an advantage in terms of survival in patients undergoing invasive treatment. And this is the only data we have for surgery. And for transcatheter, we only have a single-arm registry showing that TEER is feasible and effective in reducing MR in these patients. So the role of the minimally invasive surgery, it could be, of course, important, but we need further studies, a randomized control trial to demonstrate this. And honestly, this is my personal opinion, most of these patients are old patients, fragile, with many comorbidities. And so the risk of surgery is often not so low. And often they come to our attention with a permanent atrial fibrillation with really a large atrium with a low probability to restore the sinus rhythm with the cardioversion or with the ablation. So, I mean, I think that there is room for both procedures according to the patient profile.
Thank you.
So, Will, a quick question, quick answer for you. We have less than a minute and a half left in the session here. You showed the ESC guidelines with the QRS width being, for CRT being greater than 150. Is there a role for greater than 130, or is there a different level of recommendation? And is there such a thing as too wide of a QRS where there's no value?
Let me tackle the second one first. There is absolutely no cutoff value and above. So the wider the QRS, the worse the prognosis, but there is still benefit of resynchronization therapy, even if your QRS is 250 milliseconds. So you absolutely should offer the therapy to those patients, but you have to take into consideration that their inherent prognosis is just worse. For the 130, between 130 and 150, we also give recommendations as a 2A recommendation, depending on the morphology of the QRS there. So anything above 130 has a class recommendation, but it depends a little bit the strength on the morphology of the QRS width.
Thank you.
Thank you. So we will ask you to have the final words.
In the form of question. Well, thank you very much. Very, very nice and interesting lecture, loaded with information, useful information that we can use in our everyday practice. Good discussion, and thank you for your attention.
Thank you so much.
But I wanted to ask a question, Professor Metra, but I will do it in the pause.
Yeah. Thank you.
Thank you.
So now I believe we're going to move on to lecture 2. Is that correct? We're going to ask Ricardo to come up, and our speaker, and we'll proceed to the next session.
So it is really a great pleasure to invite a close friend of mine, Professor Cristina Gavina from Portugal. She's been vice president of the Portuguese Society of Cardiology and director of the Academy of the Portuguese Society of Cardiology. She's doing an amazing job trying to evolve the evidence of the epidemiology of heart failure in Portugal. I think she's running one of the largest registry to understand the epidemiology, phenotype, and to understand more about heart failure in her country. So it is my real great pleasure to introduce her, and she'll talk about the Portus registry. Please, Cristina.
Thank you so much for the kind presentation, and again, it is a pleasure to be here and to be able to try to show you a little bit of what we've been doing and what lessons do I think that we can get from this study, which I hopefully want to see it published until the end of the year. It has been quite a struggle, but we are just there. So I think it's going to happen. Well, anyway, just to give you a hint of why we thought it was so important. You know these numbers already. So we are not sure exactly what is the prevalence of heart failure. Even within the same country, there are very large differences, as you can see. And the truth is, we know that heart failure, preserved ejection fraction is on the rise. Probably the reduced ejection fraction is not only stabilized, but also decreasing. But we also had a previous work done in '98 in Portugal, which was kind of different from everything that was being published in Europe at the time. And this was, of course, before even ejection fraction was used. So you cannot phenotype patients here as preserved or reduced ejection fraction. But at the time, we already had, in those above 18, a percentage that was 4.4%. So it was a high percentage even for the time. Now, what is the problem for me? It is the denominator. So we are talking always, when looking at numbers of prevalence of different settings, so you can have populations that start at 40, 50, 18, there are several age cutoffs. Most of them are going to have administrative data and also already have a diagnosis. So when you think about case definition, you can go from clinical definitions to definitions with natriuretic peptides, different cutoffs again, and again, the diagnosis of HFpEF is as hard as we all know. So the problem to me was, what do we really have in the community? Do we really know the numbers? And that's why we designed the Porter study. So for that reason, we actually started with NT-proBNP. So we actually selected people over 50, and we started with an NT-proBNP as a cutoff without even checking for symptoms at first. And then those that had an NT-proBNP that was above 135, according to the guidelines, and those that had prior heart failure diagnosed were actually going through the second stage, which was a confirmatory stage. This is important because we also had 5% of those with normal NT-proBNP that also went to the confirmatory stage, so that we could have a reasonable idea how the screening validation cohort was done. And after that, we actually did the echo. And after the echo, we had people, of course, with normal ejection fraction or reduced ejection fraction, and we looked at symptoms. And only after that did we do the diagnosis. And you have to realize this is quite interesting, because from the all eligible population, of course, and this was a multi-sampling staging that we did so that we could get a sample that was actually very, very close to the census of 2021 that we had already information in. We had a participation of 6,189 participants, and these people were actually 36% of them had a raised NT-proBNP. So this was quite high, at least for our expectations. And again, from these patients that had a raised NT-proBNP or previous diagnosed, and from the screening validation cohort, we had the confirmatory stage where we did the ACG and the echo. And you can see here that the vast majority of these people did have an ejection fraction that was above 50%. And again, when we looked at symptoms, most of them are going to be symptomatic. So 69% of them would have symptoms, although they had an ejection fraction over 50%. But again, we could not be sure that this would be ejection fraction in heart failure with preserved ejection fraction. And that's why we also applied the HFA-PEF score. And with the HFA-PEF score, and just considering those that were 5 or above, we had a number of very significant number, I would say, of people that actually did have a final diagnosis. Which means that if you use this kind of tools, you will get a very, very high percentage of people actually having heart failure. And most of them are going to be heart failure of preserved ejection fraction. Please don't be too excited about the reduced ejection fraction and mild reduced, because we didn't have, of course, power enough to be characterizing such a small number. Certainly, it's going to be much higher than reported here, but the vast majority is going to be preserved ejection fraction. And even when we take off the mimics, you still have 50% of overall prevalence. And this is quite unexpected, even for a population that was 50 or above. So the first message to me is that heart failure is going to be much more prevalent if you look for it in the community. It's not the patients that you already have diagnosed, it's the ones that you're going to look for. And again, heart failure preserved ejection fraction is probably going to be the big thing for the next few years. So this is what we're going to be looking for, because the majority of these people in the community are going to have ejection fraction that is normal. Again, this is a problem of aging. So age is the most important determinant in terms of HFpEF. And the problem here goes that if you look at the numbers, so 71.7% of those with heart failure of diagnosis had actually 70 or above, which means that 1 in every 3 participants that did have more than 70 actually would have heart failure considering this classification. So this is clearly a disease of aging. Then again, women are also very involved, in particular, in this type of heart failure. We already knew that, right? But the problem is, it's not just about age. You could say, well, women are older. Yes, it's true. But still, they have clearly more heart failure preserved ejection fraction than men. So there is something that probably is also sex-specific. And the prevalence is as high as twice that as you can find in men. So we have here a problem, of course, with women. Again, if you look at what happens in terms of comorbidities, and yesterday we were talking about this for a long, long time, truth is that probably this is also not only a disease of the elderly, of women mainly, but of people with comorbidities. And you can see here that all these are independent factors that are associated with heart failure preserved ejection fraction in our study. So it means that this is the burden that we are facing now to have these patients diagnosed. And again, the problem also is, if you go to the community, most people are not going to be, of course, aware of their diagnosis. They're walking around. They haven't got to the emergency room or been admitted because they have heart failure due to, like, say, infectious diseases. So this is the problem. Of course, people with reduced ejection fraction were more aware that they had the disease, but the ones with preserved ejection fraction clearly were not aware. So this is going to be the problem that we have to look for in the community. Again, quality of life is going to be important. And you would say, well, probably this is all pre-heart failure. Probably these patients do not have many symptoms. Well, they're not very symptomatic, of course. But if you look at this, and this is interesting because we did the KCCU questionnaire in patient or in people that had an NT-proBNP that was raised, but had no final diagnosis of heart failure. And if you compare those guys, and they're not totally normal, remember, because they have raised NT-proBNP, but the KCCQ is different from that of those that had a final diagnosis of heart failure, which means that their quality of life is actually not the same. And again, using this type of screening at a population level, using NT-proBNP as the first step, even before you look for symptoms, can be useful because you can have actually a very, very high negative predictive value from all the patients that we screen in, even for our validation cohort. Only one patient escaped, let's say, and it was a mildly reduced ejection fraction. So this is important because we have to realize that if you're screening in the community, you have to have a very high negative predictive value. And again, this is not a yes or no answer. This is going to be much more complex. And I mean this because I'm really eager to know what happened to these patients. And these patients are the ones that are in the gray zone. So the asymptomatic patients that have raised NT-proBNP, changes in their echo, or people that did have symptoms but did not comply with the HFA probability or high probability of having HFpEF. So these are going to be probably the most important data that we are going to collect further on to see if these people actually are going to do better or equal or worse, because we really don't know what to do with them. So just to end, just to say that this is what you get if you use contemporary diagnostic tools to try to look at in the community. And when you do that, you realize that the paradigm has to shift. This is something that we should be looking for and treating in a preventive way. And the thing is that if you know the risk factors, and those comorbidities are quite frequent, as you see, if you know the risk factors, probably we should step in to treat the risk factors and not wait for patients, of course, to come to us with an ejection fraction which may be preserved, but at a moment where the diagnosis is made in hospital. So thank you very much.
Thanks, Christine. It was amazing presentation, and we can switch. I mean, it's the same. No, she's gonna talk, and I'm gonna talk. This is incredible, and you know, this is actually the demonstration that how we can implement healthcare system. Just thinking about, we do prevention for breast cancer, for prostate cancer. But we don't do any prevention just to dose NT-proBNP in the population. If you think about like in a parallel way, right? And I think this is important in your country, but it's a message for any healthcare system across Europe. So we should focus on that. And I'm so like surprised that you were able to do this examination. A couple of comments. First of all, how do you explain? I mean, it's the epidemiology trend, but I'm so surprised that most of your patients were non-preserved. EF. This is absolutely like probably one of the first real scientific evidence that if you test everybody, you'll find more PEF than MREF and REF. And also the second comment, all the time we think about AI, scores, you know, everything that we have in our mind that is good, but at the end of the day, we just need a biomarker that is not expensive, it's available in any hospital, everywhere, in any patient, and we have, I would say, a diagnosis or at least a suspicion. So I would like you to comment these two points.
Sure, thank you. I think that we're just scratching the surface here. So the problem is that we are starting the same, or we should be starting the same path as we're doing in diabetes, looking at the NT-proBNP as a stress marker, and probably that's what we should be doing. Now, if you ask me if I do believe that this is true HFpEF, I don't know what is true HFpEF. I'm not sure if anyone here knows what is true HFpEF. But the truth is, these are the ones that were mostly tested for the drugs that nowadays we use, and they work, at least in a cardiorenal metabolic setting, which is exactly the setting of these patients. So what I think is, and at the end of the day, and you have to consider that Portugal is the second oldest country in Europe after Italy, and we are actually facing this problem of aging, and these people have to age better. So they're going to have an age heart. Everyone is going to get there. But if you get there later, it's going to be better. So if you can do something for them before, probably you're going to have a better result. So I don't think that the question is going to be about if you are having a lot of HFpEF. It's about the comorbidities that lead to HFpEF, the age that leads to HFpEF, and how you should use these biomarkers to better target the ones that will need earlier intervention. And with that, I am quite sure that you're going to take a lot of patients out of hospital, because right now, as we are in winter, most of our patients are going to be 80+ patients that are coming in and out with every type of decompensation of heart failure. And this is the problem. These are the people that are having the most consumption of money because of their health issues. And these are the ones that we should be actually looking for before this happens, because that's the only way our health systems are going to be sustainable, I would say.
This is great, and I think that you are also, I mean, doing this enormous work, you are preventing, because I assume that, and this is a kind of technical question, like all these patients will be treated and otherwise will not be until they will have an event, right? So how you are handling all of these patients and otherwise will never come in your institution?
It is quite interesting. So we went to 22 different localities in Portugal when we had a truck, real truck. I mean, this was a mobile clinic where we did everything from the point of care NT-proBNP, blood testing, and we send the blood to a biobank, and we have more than 5,000 samples there from DNA, RNA, and blood. And then again, we did all these echoes there. And this was totally very important to get people to actually not fall off the trial, the study. But then again, what I think it's important also is to realize that if you do this, and you actually send their GPs a letter explaining that they're having a high probability of having heart failure, which is what we did, because we didn't start treatment. We didn't have that kind of ability. So we gave them a letter to take their GPs so that they could actually act on it. And it is interesting to see that we went across the country doing several meetings with their GPs so that we could actually make them understand what was the next step after getting this information. So we are looking for the 1-year data of this follow-up of these people that were diagnosed to see if it actually impacts the way people were treated and the way they were referred, because as we know, many of these people are going to actually be referred for a specialized heart failure clinic. So I am wondering exactly what is going to be, in the end, the impact, but I'm hopefully thinking that it's going to be good.
Amazing. This is not supposed there to be like questions, but if anybody has a question, of course, it's a good time. Please, Marco.
Mitja Lenschak from Slovenia. Oh.
Yeah, just for time, yeah.
A couple of comments. We also did something similar.
I know, SOBOTA-HF.
Yeah, SOBOTA-HF, yes.
Of course, I read it.
And you did point of care.
Yeah.
I think that the reason for low prevalence of HFrEF is that the people who know that have heart failure didn't attend. That is in particular true for HFrEF. We have seen the same. And then the proportion of elevated NT-proBNP was 30-something, 36%. We had 54.
That's
54, and it was then validated with in Hostel where it was 48, but we had 5 years older population. Maybe that is one of the reasons. So it's very, very common. And I would just like to add something for everybody, that it should be done by the GPs, and if the patient has symptoms and elevated NT-proBNP, they should receive SGLT2 inhibitor before referral. We just completed a study where we did that. So patients with symptoms, elevated NT-proBNP, and then referred for echo.
Yeah.
Out of 100, only 1 had no indication for SGLT2 inhibitor, either renal or heart or something.
Yeah.
So you don't then waste the time of 3 months in Slovenia before echo. Or other indication for SGLT2 inhibitor, either diabetes or chronic kidney disease, but less than 10%. The rest had abnormal echo, yes. These were elderly people above 65 with the GPs. So extremely common. The older the population, women older than 65, this is...
Yeah, I think that the main message is that we should not wait until a specialist visit or care, but the GP should be the first to provide the right treatment for this patient, regardless of the echo, regardless of...
I would just like to make a comment, which I think it's also important, which is from the people that refused to come, which are the ones that I was expecting, of course, that had a previous diagnosis. We weren't allowed to ask that because the Ethicals Committee, once we were calling them to, because we have a national health system, so we have everyone in the system, and we called people to invite them to participate. And the problem was that I wasn't able to know if they had or not heart failure, previous diagnosis of heart failure for those who refused. But interestingly, those who refused were the eldest because they didn't get any type of transportation or they were afraid. I wasn't expecting that. I was expecting that it would be like 50-year-old male that wouldn't actually come, that was already in hospital because he had an MI or something. So it is interesting.
But so all your patients had echo?
Yes.
But in your case, they were mostly in the gray zone, 2 to 4 FPEF score.
Yeah, we had a lot of people, 500 people that were, well, we had the final, let's say, diagnosed, the high probability of having FPEF were 1,100. But we had 500 people that were in the gray zone. And then again, we had 700 people that were actually asymptomatic, but did have a raised NT-proBNP and changes in their echo.
Okay, the bottom line, I think these are the studies to be done. further, because as heart failure community, our fellow specialists, we must clearly state then that NT-proBNP plasma measurements should be routine clinical practice, as well as we measure serum creatinine, hemoglobin, cholesterol. I mean, it's the best way we have to screen the subjects. And now we have the treatment. So I'm wondering about the funding of, were they funded by the government or?
No, we had the funding of AstraZeneca. It was.
Okay, sorry, I missed
No,
it.
our government doesn't have any money, believe me.
But I think it makes sense because the companies have a good reason.
No, this was actually a joint venture from the Portuguese Society of Cardiology, a university, and AstraZeneca.
It's a good way to spend money. And the other thing, just to end up, I would concentrate on older patients, more than 65 or 70 years old. The other thing is that, I don't know if you, but now there is, Milton Packer is saying that it's all about adiposity. So I hope you measured the waist circumference.
We have it.
And of course, we need to adjust for adiposity, but it would be extremely important that we are in Europe, not in the United States, and good reasons to be in Europe. And so it would be very important to check the percentage of patients that had with increased NT-proBNP.
We had.
You have already.
We had 28% of people that were above 50 were actually obese. So they had a BMI that was
25% is not
28%.
28%. Well, it's not because
it's
in
not
Paragon
like
it's 96%.
Yeah, but we do.
Adiposity, 96%. So and obesity, I think, was 45, 50%. So I mean, it's important to say that HFpEF may also occur in non-obese or non-adipose patients in Europe, at least, because I think it's, for example, the phenotype with pulmonary hypertension, right ventricular dysfunction. So you're much better than.
Thank you, Marco. Thank you, Christina, for a very interesting presentation. I hope you will publish your paper tomorrow. But the question, your lecture and your study opens also some ethical dilemmas. On one side, we have a perhaps large population with undiscovered serious diagnosis. And on the other hand, we have this, what ethical experts call medicalization of the society. It opens question, profit-driven, you said. AstraZeneca they have a legitimate cause to bring in profit, and we are medicalization, our citizens, right? But my question to you is, how many of these, I understand that they didn't know that they have HFpEF. Mm-hmm. How many of them you started actually treatment?
I didn't start treatment in anyone.
Why not?
Because they were supposed to go to their GPs, because that's the ethical way to go. I shouldn't be starting treatment on them.
Do you have data how many went to GPs and eventually?
I will have it. Next year, I will have that data, because we are actually waiting for the government to give us the data. And
if you are to speculate, giving your knowledge of
really,
Portuguese.
In the best case scenario, I would say that 30% would be medicated in Portugal.
One comment about the funding. Why these studies are not done? Because they are extremely laborious. So in our case, we had more than 1,000 subjects. Then with detailed examination, it was 2.5 hours per person, and in 2.5 hours per person per subject. We did many things. And then in one of my previous lives, I was director of the National Funding Agency for Health Science in Slovenia. And I always said to defend medicine, who is the largest sponsor of medical research are the healthcare professionals, because they do everything on top of everything for free.
That is totally true.
That is true, yeah. But for our study, we had the national funding, which was 220,000 euros. So this is surely not enough to cover the expenses, and nobody wants to invest in that. And I think that this is something where professional societies should step in and get the grants from the European Union to do that. There is one project which is the largest project in cardiovascular disease, and the second largest funding in Europe from the European Union is called JACARDI. That is joint action on diabetes and cardiovascular disease with 70 million plus funding. And it's now ongoing also in Italy. So Rome is coordinating. So I think that should be something for the future, to spend the public money to do the epidemiology. Otherwise, it will not happen.
Absolutely.
You need the follow-up to demonstrate that these subjects are at higher risk. But when you go to subjects that are above 65, I think it's good to raise a concern in the subject about higher risk. And of course, the other thing would be to have something like Stop HF or Pontiac with an intervention group and a control group, but again, this needs even more support.
I would love to do that, but
Yes,
I just don't have the money yet.
Yeah. No, it's impressive, the 2.5 hours per subject. Well, you do the blood sample,
Yeah, the questionnaires and the echo.
Centrifuge.
And we have ACG for all these people also, which we are going to analyze with AI. Yes.
AI may be better than
we had,
NT-proBNP. In that case, okay.
You have to realize that we had 2,500 echoes. We have it in our data lake has all these images to be analyzed for strain, for whatever we want in the future. But this is a lot of work. I mean, you have to have money to make that kind of analysis, yes.
I think it's a wonderful study.
Impressive. Really impressive, and I'm pretty sure that next year we will know something more with more data and more publications. So thanks, Christina. This was an amazing talk, and thanks everyone. I think that now we have lunch. Gianluigi is not here, so please have a good lunch and see you in a bit.